Hi, everyone. Welcome to today's office hours. Thank you for joining us. Um, for today's panel, we have Dr. Phillipson and Dr. Greeley presenting. And then, as a reminder, no PHI may be discussed since we record and post these sessions. And our first case we pulled from our monogenic diabetes registry study here at U Chicago. We can go ahead and get started.
All right. Well, welcome everyone, and I'm glad, we have Dr. Paulin and other experts who are also on the call who can help me out. So this person and contacted us about her family a few months ago, and we've had some back and forth. And Ava, was going to present, but I just thought I'd do it in the interest of time. And also, this is one of the more difficult things that we see in terms of there's a mutation, but is the mutation the cause, and how is that possible? And so those are the dots that we're going to connect. And I wanted just to thank Dr. Kandasamy also for putting the mutation together and going back also to the historical relevance. So we'll talk about that as well. So 51-year-old person who was diagnosed with diabetes at age 25, maybe slightly overweight, 5'8" and 180 at the time, but the sugars were quite high, was apparently in DKA. Birth weight not excessive, but certainly on the high side. And recently had a C-peptide. We don't have the simultaneous glucose, but the C-peptide was certainly not zero. And we now, I think, Ava, she said that the antibodies were negative. So,
Correct. Yes.
so the usual antibodies have been negative, and has been on insulin, also metformin, um, and you can see she's lost some weight. A1Cs are in the sevens, but has been as high as 9.5. And on the next slide, um, unfortunate breast cancer diagnosis, also on a statin and a ACE inhibitor. And then the family history is what really is also very interesting. Mom was diagnosed with diabetes at a young age on diet alone, uh, 5'1" and 140, and a A1C just in the range of diabetes. Brother, 52, diagnosed weirdly enough at age 51. Uh, Seems to have a similar situation, and we don't know about his children. The son, so this is the propositus's son, DKA also at 16, we're told. Oddly enough, Victoza and metformin, A1C is not great, 7.8, and another daughter seems to be negative. So then we have genetic testing was done when the antibodies were negative. I think the next slide, maybe. So everything else was negative, and this thing came up. So this is an ABCC8 mutation variant, which is in the sort of the end, sort of towards the end of the molecule. Serine at 1418 is replaced by an arginine. And so interestingly, it comes up as likely pathogenic, but for what? Because ABCC8 is very complicated. So if we go to the next slide, uh, let's see if we can do that. So what this is pathogenic for is hyperinsulinism, not diabetes per se. So this variant, and it's not new either. So we'll go through that in a moment. So it has been reported in hyperinsulinism, especially as we've said in trans in one case with another variant. So it says experimental evidence. So this is a paper from our colleague Fran Ashcroft, who is well known to people in this field for her work in ABCC8 and KCNJ11. Fran published this paper in 2002. So this is not news. And what she did report back then by doing mutation and expressing the channel in a cell line was that it caused a loss, or at least a partial decrease, in magnesium ADP dependent activation of the KATP channel, which said, okay, there's a loss of function leading to hyperinsulinism. So that supported this notion that this particular mutation can cause increased insulin secretion. It has a high Revel score, so again indicates that it's a damaging mutation. Very low frequency, so there are a whole lot of zeros there. One, two, when there's 5 zeros, it's interesting. Um, Extremely rare allele. And they said, where is it? So it's in this nuclear binding domain linker, which had been previously established by Fran and other people, and we'll come back to. Also, there's some papers from Colin Nichols and his group very recently, again, on this idea, and I'll come back to that in a moment. So likely pathogenic, but not for diabetes. And what else is going on? And did anyone actually ever have hyperinsulinism? So, of course, from the history, this was about diabetes. It wasn't about hyperinsulinism. However, there are some at least larger babies here, including our main subject, who so maybe there was some intrauterine growth increase, macrosomia. But if there was hyperinsulinism as a neonate, it was missed. I mean, we didn't hear about any hypoglycemia in any of the people in this pedigree. We want to say that, thank you. So sometimes these variants are mild, so that happens, and sometimes it has been reported in ABCC8 cases that without even with these mutations in those individuals who have maybe modest penetrance, there's no neonatal hyperinsulinism. Diabetes may appear in adolescence or adulthood. And that has been published, and we can go through some of that next, I think. So the next slide. So this was the question. So what is the treatment? So of course, it's hard to put a treatment together without understanding how this can cause diabetes when it's linked to hyperinsulinism. So very recently, and I'm talking about now January of this year, there were a paper and a commentary came out, exactly on this point. So the paper was from Colin Nichols' group in St. Louis, along with Radha Venkatesan was a co-author, so it's possible the subject in that paper was from the Chennai group. The paper is called Paradoxical Maturity Onset Diabetes of the Young, Arising from Loss of Function Mutations in ATP-Sensitive Potassium Channels. So that title, Paradoxical Maturity Onset, tells you that this is confusing. And that paper appeared as the January issue of Diabetes. The first author is Scala, Scala. We'll provide the reference for those who are interested, but it was, if you want to copy it down, it was volume 75, page 180. Along with that was a commentary from our colleagues, Dr. Barbetti in Rome, and Paul Thornton. So that also appeared in the same issue, and the title of the commentary was ABCC8 Missense Variance and Disease, Loss or Gain. So all of this reminded me, interestingly, of a commentary I saw recently from Blake, the poet, who wrote a series of maybe aphorisms about heaven and hell, and one of his was enough or too much. That was it. That was the whole thing. So you have to think about that. And so that's what we have here. Is this a loss of function that became somehow a gain of function, or the other way around? Or does that, even the terminology actually doesn't make any sense here? So the idea that Colin Nichols has been working on for a while, and the subject of his paper, was that he said, and this is a quote from the paper, "Our data provide definitive support for a paradoxical form of MODY associated with the KATP channel loss of function that is genetically and mechanistically distinct from a late diagnosis of neonatal diabetes resulting from a KATP gain of function." to avoid confusion, if you're not confused, you don't understand the situation. So it says to avoid confusion and inappropriate treatment efforts, we argue that diabetes driven by these mutations, gain and loss, should be officially recognized as distinct diseases. Now, the Barbetti commentary says maybe not so fast. We don't really understand what's going on here. So this was done. So, Kristen, so they did a panel. So I believe this was a next generation panel, but I'm not sure. I think you can go back to the just for so we can answer Kristen's question. So yeah, this was the report. And I don't remember what company this was this Invitae? I don't
Yeah.
remember.
Oh
Yeah.
no, I'm sorry. I was talking about the person who wrote the paper.
Oh, oh, oh.
Like where are
So
they getting? Yeah, like it's like if you only looked at.
well, this is Colin. So Colin Nichols has been doing this, since he was. So the history is that Colin in St. Louis is an ion channel guy who has been studying KTP channels for 35 years, maybe before they were cloned. So he came to us from the cardiology field. He did a lot of work in cardiac KTP channels, and then there was a sort of an interesting group of people with Fran Ashcroft, Colin Nichols, Lydia, and Joe Bryan, and of course, then later on, Susumu Senu, who were involved in understanding channel function and then cloning the channel. So that's Colin has been in this for a long time. So I'm not sure that probably didn't answer your question, but they have been doing, I think, targeted exome sequencing to identify their patients. But is that maybe
Yeah,
I'm
I mean, I guess it was more of like how can you claim that this is the definitive answer if you only looked at ABCC8? I guess that was what I was
well,
going
so
to.
yeah, so look, so this is really about ABCC8. So I think
Gotcha.
yeah, it may be that there's some generalizability here, but he's talking about specifically, I believe, KTP channels and ABCC variants in particular. So then the question is, what is the pathophysiology? How is it that some individuals who have either clinical or subclinical mutations that cause hyperinsulinism, why do they go on to develop diabetes? And really, so profound. I mean, that several of the people had DKA and then, still have some evidence of insulin secretion. So I don't think we understand the pathophysiology. In some cases, it's been said that the beta cells die, uh, in fact the overactivity early on, which causes the hyperinsulinism, means the beta cells are seeing a lot of calcium, there's depolarization, and so you could have something called excitation-induced cell death. So repeated amounts of high calcium are causing the cells to die. Another possibility would be that they're not dead, they're just badly wounded, and they've at some point give up the ghost. So they're so much involved in hyperinsulinism, even though the people don't have hypoglycemia, that with time they run out of the ability to make insulin and they can't compensate anymore. So you have decompensated insulin secreting cells that are not dead, but just not functional anymore. Now, you would think they could be resurrected. I mean, I suppose maybe it's too close to Easter to do that, but the idea is that they could be rejuvenated, maybe that's a better word, by a GLP-1. And here, in fact, at least one of the family members had a GLP-1. So would that help? Some people say, well, it's diabetes related to ABCC8, so maybe we should give them sulfonylureas. That seems like to me exactly the wrong thing to do if in fact hyperexcitability was the thing that caused eventual diabetes. But we don't have a big enough N of these cases to fully understand what the options are. So in here we have again this pedigree. Some people are on nothing, some people are on insulin, some people are on insulin plus metformin, and then the idea of a GLP-1 in this case maybe I think it was Trulicity. So I think this is a bit of a conundrum at this point, what the best option might be. we certainly want to collect more of these cases, maybe then historically see if people have been given GLP-1s and whether they're doing any better. Some of these folks are thin, but here in this family, at least one of them had already lost 20 pounds and seemed to be the better for it. So that maybe one of the newer GLP-1s was going to be useful. And you can see there are other family members that haven't been sequenced in that original pedigree. In fact, go back to that. So make sure that everyone sees that family history. So this one. So again, so we have the propositus who's at the very top. I mean, who unfortunately has breast cancer. Then her mother, her brother, and her son, and a daughter. And there may be other people in the extended family that other sibs and children of sibs, nieces and nephews that we haven't fully captured. So a variety of different medications. Diabetes after the initial DKA presentation doesn't seem to be too terrible, but it's certainly a problem. And in this particular family, I can tell you that there's huge frustration. So here we have diabetes, why do I have diabetes? And all these same questions. What's the best treatment? How do we think about this? And will my other children get it? So yeah, I mean, the other children, if they're not sequenced, it's certainly possible. But I don't have a sense of what the best treatment is. I certainly would lean towards a GLP-1, maybe insulin to support those times when we see that the C-peptide is low. It might be interesting to get a glucose tolerance test with C-peptide over time in the context of a clinical study. And it's possible that Colin Nichols is doing that sort of thing. So maybe it would be great maybe to stop here and see whether people have observations or suggestions or, somehow want to either increase or decrease the level of confusion.
I actually have to drop off in a few minutes, but just remembering this paper, and what I remember about this paper, or the paper that you're talking about, is that there were some variants in it that were like too common, but they were saying were causal. And I also this paper was also just a reminder of the limitations of the language around loss of function and gain of function. And I mean, they did a lot of really complex functional studies, but yeah, it was not, yeah, I wasn't totally convinced.
Yeah,
So I don't have
and
anything
just to remind, so
else.
in this particular case, I mean, this
Yeah,
exact mutation was studied, as I mentioned. I just want to make, so it was a paper from Fran
right.
Ashcroft, right?
I
So it
didn't
was
mean that paper, but
I
yeah,
know, but
yeah,
so it doesn't help that, that it gets confused. So, actual righteous mutations that seem very strong where there's cellular evidence with things that are not so strong. But the paper
yeah.
I didn't mention. So the title of Fran's paper is Mutations in the Linker Domain of NBD2, the nuclear binding domain 2 of SUR, sulfonylurea receptor, inhibit transduction but not nuclear binding. And that paper was in the EMBO journal in 2002. So that was exactly this variant,
Mm,
if I recall properly.
yeah.
So, and there were some other variants also mentioned. So I think that, that pretty much establishes, that this variant is doing something, but why the transition? So
Right.
I don't,
Yeah, really interesting case. Thank you.
yeah. All
I have
right.
a couple
Thank
of
you for
comments.
joining us. I appreciate that.
And I usually, when I make comments, I don't necessarily make it less complicated, but I would, since Tony is here, just want to emphasize that we have currently gene curation groups of experts who are wrestling with this very question that Dr. Nichols' paper mentions, like wanting to, officially recognize different conditions, as though, we haven't already been trying to do that. We've all kind of been aware of that from the beginning. The question is, when you are approached with the patient for the first time, how can you be sure? But the idea of the gene creation efforts is you're curating, this condition, like the hyperinsulinism condition and the diabetes condition separately. And we're doing that first step. The next tougher step actually is the variant curation part of it. And hopefully, over time in the years to come, we can be part of those efforts too, so that when these variants are found clinically, we'll have a better idea going into it from what's been known before. And then really the key thing is comes down to the genetic testing report and what they are calling it. And that's something our MDEP group with Tony is also trying to do, is like really involve the clinical testing labs so that they can not increase the confusion, but hopefully decrease the confusion and lead the clinician down the right path.
Just to
Um,
amplify that alone, I mean, we've seen in many other cases where the report says pathogenic, but it isn't pathogenic for what the patient has. So that
exactly.
comes up over and over again. And how is it that, there's a disconnect there? So you've seen that
Yeah,
too.
I really am gonna have to step up, but I want to say something about that because this actually comes up as a variant a different gene that came up recently with the ClinGen. So one of the points that was just reemphasized to me by Heidi Rem in a communication I had with her about another gene is the curation is for the variant, not for the patient that you're curating it in. So yes, this is a likely pathogenic variant for autosomal recessive, but autosomal recessive congenital hyperinsulinism. The problem, I think the biggest problem is that you have, and that I think we're trying, but it's like there's only so much we can do. We work with people from the labs, but then they have the corporate that really make the decisions that should be more the scientific decisions. But there's a problem with basically the issue is with labs that don't necessarily have a lot of in-house expertise about that particular condition. So they're saying, yeah, this variant, this gene is associated with this and this and this, and this variant is likely pathogenic, but they're not really telling you, what it's for. And that's we ABCC8, both the gene and variant curation have been on our list for a long time, and we're working on it. And part of the problem is that these issues have challenged us so much that we haven't yet gotten there. But this reminds us that we need to get something out there, even as it's going to be malleable. So thank you.
yeah. Yeah, thanks for joining us, Tony. Um, I have like maybe two other points. One is just to remind that some of our other favorite Modi genes can also have a similar picture of neonatal hyperinsulinism and later diabetes, namely HNF4 alpha, especially, but even HNF1 alpha can do that sometimes. And I'm not saying that they have the exact same mechanism, because we have a lot of reason to believe they're probably pretty different mechanisms, but this is a phenomenon when you have dysregulated, messed up insulin secretion. This can happen, and exactly as Lou mentioned, oftentimes the neonatal hyperinsulinism can be highly variable and may not have been that clinically significant or caused overt hypoglycemia. But I do think the one objective, or possibly objective marker, the best one we have in those instances was mentioned in the case details there, is the birth weight of the baby. And I think that's particularly helpful in this one because the diabetes variants are going to have uh, usually a lower than average birth weight. They can be normal, but on the lower side of normal, or lower than normal. Whereas the hyperinsulinism variants should be in the higher range of birth weight. And so that can actually be a really important detail to try to get, even for the extended family members, and the likelihood that the variant is, one of these hyperinsulinism variants, or if you have diabetes variants. So I think that's a really important detail. And then lastly, about the treatment, I don't have much more to add to Lou, except I'll say that from way back in the day, people like Charlie Stanley at CHOP have been fans of metformin, uh, without having like long-term outcome data on that really. And I'm not sure it's obviously not going to be enough for everybody, like the son in this case who's on metformin and Victoza. But interestingly, the last point I'm going to make is that son in the case here, who is on just metformin and the smallest dose of Victoza and has an A1C of 7.8%, that's clearly not insulin deficient type 1 diabetes, even though he's being, maybe inadequately treated. Clearly, he doesn't have type 1, and yet he presented with DKA. And so that was kind of the last point I was going to make, which again is not making this less complicated, but it's really kind of fascinating that they can present with DKA and then go on to have what it looks like a really relatively mild diabetes, which almost makes us think of, I don't even want to mention it, but the like ketosis prone kind of picture. But there is mechanistic data supporting some of these concepts, at least in the diabetes variants and some of the mouse models that they show that basically when you have these dysfunctional channels and they're overwhelmed and the hyperglycemia is going up and up and is long standing, that the channels seem to just become so dysfunctional that the cells can actually kind of go into a quiescent state and just not work very well. And that can look kind of like insulin deficiency. But if you are supporting them and treating them appropriately or consistent, we think you can get pretty good function out of it. But I do agree with Lou ultimately that probably low dose GLP-1s, plus minus metformin are a good place to start. From there, whether you go just to insulin or, I don't know if I'd even mention SGLTs when you have DKA, but again, if it's related less so to true insulin deficiency and stabilization of the cells, might be a consideration. But there's a lot of unknowns here, and it would be great to try to get more data and outcomes data on these patients, which we're, by the way, trying to do with our data commons effort with multiple institutions, gathering real patient long-term data on these kinds of really rare cases so that we can hopefully over time answer some of these questions a little bit better.
All right. I mean, I think that is really an instructive case, and we will continue to compile them and hope we can say something definitive in the future. And it may be that Colin has actually had mouse models of ABCCA, but I think that actually mice are different and they're also confusing. So, all right, we can do the next case.
So for case two, I also pulled this from our registry here at U Chicago. Siri, did you want me to go over the case information? I'm happy to.
I guess I can present it
Okay.
if but please correct me or fill in anything. So this is a case that has been in our registry for I think a couple of years that is interesting and instructive, hopefully. I think currently a 12-year-old girl whose diabetes was diagnosed at age 8, which is actually quite an unusual age for any form of monogenic diabetes. Her weight at that time, the BMI was on the very low side of the fifth percentile, which relates to the medical history that we'll get to of a congenital heart defect. Um, the diabetes control was okay, not great, with an A1C of 8.3%, having some ketones, but apparently didn't have DKA. A couple of C-peptide tests that have been done, I think around diagnosis and then sometime after. The C-peptide looks pretty well preserved. In fact, it went, well, I guess it went down a little bit, but those are, they can be, um, they can change, but both of them are show pretty good, decent insulin production. The diabetes-related antibodies were negative. Currently taking just 5 units of long-acting insulin Tresiba, per day, and with what sound like pretty small doses of bolus rapid-acting insulin, with like a unit per 20 grams of carbohydrates. So a total insulin intake requirement of about 6 to 12 units per day, or 0.3 units per kilo per day, which I would say goes along with the preserved C-peptide, that it's not like a complete replacement dose of insulin, and different than our typical type 1 case. They had been briefly trialed on glyburide, which I am sure that we did not recommend that. I don't know if that happened before they even were in touch with us, or if they just wanted to be sure. But the sulfonylurea glyburide did not seem to make any difference, so fortunately they stopped that. Currently, the BMI remains on a little bit lower side, but a little bit better than when they presented. So now 23rd percentile. The A1C shows that they're now extremely well controlled with their diabetes at 6.6%. And I think the next slide, do we go over some of the congenital diabetes or congenital heart defect history? Yeah. So I think after the diabetes diagnosis, they did an ultrasound to look at the pancreas. That might have been something we suggested. And the pancreas appeared to be atrophic, but was present. And by ultrasound, it's difficult to be completely quantitative, and yet it can be pretty useful because ultrasound can tell you if the basically if the pancreas is present and looks normal, or is it present and looks abnormal, or they couldn't even find it, which is what we often see with cases with complete pancreatic agenesis. So this case does not have complete pancreatic agenesis, but has a somewhat atrophic, smaller pancreas. The mom, during the pregnancy with this infant, the baby was noted to have IUGR, so there was concern about the baby being very small. And they actually found the congenital heart defect while in utero, so they knew that was going to be a problem when the baby was born. So they might have had a procedure soon after birth, and then they had another procedure at 11 years old. And they've since had, it sounds like, a couple of episodes of atrial flutter and rhythm issues, which are fairly common when you have these complex congenital heart defect repairs. I'm sorry that we don't have the specifics on the congenital heart defect for anyone who likes those kind of details. But not surprisingly, given the congenital heart defect, the kiddo was found to have a pathogenic or presumably pathogenic variant in the gene GATA4. And so GATA4, along with another gene, closely related gene called GATA6, are both very strongly associated with congenital heart defects and often with diabetes, which is usually earlier onset, but if not neonatal, then can be younger in childhood, as this one was. The variant is heterozygous, and yeah, I guess by ACMG criteria was considered pathogenic, even though there are really not very many of these cases out there. And as we might expect, there's no significant family history of diabetes. And that especially makes sense given that both parents tested negative for the variant, which means the variant was de novo in the baby. And so we wouldn't really expect to have a family history, even though the variant would be autosomal dominant. Like, for example, if this patient goes on to have children of her own. Uh, what else do we have? Anything else? No. Okay. So, I guess as I went along, I covered a little bit of the details, but I'd say the main take-home message, I want to be like super clear for anyone listening now or listening to this recording in the future, is if any patient who has a known congenital heart defect develops diabetes, especially earlier in life, they really should be tested for these, especially these two genes, GATA4 and GATA6. Of course, the usual things could be done first, like testing for antibodies. If they're very positive antibodies and it looks like type 1, I mean, maybe you could have two completely separate things. But given that, congenital heart defects are not that common, and it's not like uh, diabetes is a very clearly known association, but I think there are many cases out there probably who haven't really been recognized because of this. In fact, we published a paper in conjunction with the NPOD group, which is through the University of Florida, a longstanding study where they take the pancreases of unfortunate individuals who have died but had diabetes. And amongst the cases that they had identified that the pancreatic histology looked very unusual, or the pancreas itself had looked very unusual, we helped do some testing of monogenic diabetes genes and did find at least one case with a GATA6 variant in a case that had a very abnormal pancreas. And I believe the diabetes in that individual was diagnosed around like 16 years old. So, and there have been a few other cases reported in the literature like this. I think the oldest might have been in the 20s, something like that. So it's certainly worth considering. So that's the number one take-home message: congenital heart defects and diabetes. Think about these genes that cause congenital heart defects and pancreatic problems. So they're involved with the overall development of the whole pancreas. So you get a smaller pancreas that affects both the endocrine pancreas and the insulin production, and also the exocrine pancreas. So an astute observer here might ask, well, in this case, did they not have also exocrine pancreatic insufficiency? And you know what, Ava, I probably should have asked you to put those details in. I know we were in touch with the mom recently, and she explained that they have been seeing a pediatric gastroenterologist, and they've been periodically testing this case for, I believe, fecal elastase levels, and those have so far been normal. And I believe mom reported that the patient's bowel movements, the stools have not been suggestive of pancreatic exocrine insufficiency. I don't know how much we want to go in the detail of what the bowel movements can be like when you have pancreatic exocrine insufficiency, but it can be somewhat unpleasant, foul odors, floating stools, what we call steatorrhea, because without the pancreatic enzymes that are involved with absorption of both protein and fat, when you start to be deficient in those, your bowel movements that can really change a lot. And so they should be tested for pancreatic exocrine insufficiency. If that occurs, then patients can take oral supplements or pancreatic enzymes. And but this case so far is fortunate enough not to apparently have that problem. But I will say that we actually just published a paper, and I guess Ava, we probably should have put that paper in here for posterity. But we did a review of the cases within our registry who have pancreatic hypoplasia or agenesis, most of them due to GATA6 mutations, but one or two with PDX1 homozygous mutations, and then I believe, if not this case, another case of GATA4 was also in that publication. And kind of some of the important things about those cases is just the great difficulty with the management of the diabetes when you have both the pancreatic exocrine insufficiency and this extreme insulin deficiency. Their blood sugars are all over the place. They they can go super high, and then when the food is finally absorbed, and then when they are given insulin, they can come crashing down because they tend to be quite insulin sensitive. And so the use of technologies like insulin pumps and continuous glucose monitoring is really, really helpful for those cases. Um, in the ones that have the pancreatic exocrine insufficiency, the dose of the enzymes is seems to be a real challenge sometimes because in those with the complete agenesis, the dose is often higher than what the pediatric gastroenterologists are used to dealing with in other conditions like CF. Um, so those are some of the issues there. Interestingly, in the ones who don't have much of a pancreas, they're also missing their glucagon secretion. And we think maybe that's why those cases tend to actually not have very much DKA, as far as we can tell, even though their hyperglycemia can be quite severe. But for this case, the good news is that their diabetes is seems to be relatively mild, and they seem to be doing really well on very low doses of insulin. Given the preserved C-peptide production, you know, I, I think there's even possibly a consideration of other medications as a strategy, because what we don't know in a case like this is the atrophic pancreas that's there producing this insulin. You know, is there any reason to think it's going to be a progressive loss of insulin production, or is, that insulin production gonna potentially remain pretty stable? And so it could almost be thought of as maybe a little more like type 2 in that sense, um, rather than type 1. But again, this case is also very young and also very thin. So, we wouldn't jump to a GLP-1 medication necessarily, but as we were talking about in the last case, GLP-1s at a very low dose do not necessarily cause weight loss, but might support healthy insulin secretion. And so that might be thought of. In this case, given the preserved insulin production, I think maybe SGLTs, although again, we worry a lot about complications like euglycemic DKA. So, at the end of the day, insulin treatment is a very reasonable option. I think when we reach out to the mom, we encourage them to think about use of technologies. So I think they're using probably CGM, but even if their doses of insulin are relatively low, there's really no reason not to be on an automated uh, insulin pump system in order to, get the best overall control with the least amount of, effort from the patients. We're big fans of those in our clinic, so I think that's a good choice for anybody. Ava, am I forgetting anything else? Or Lou, did you think of any questions or anything else we should mention there?
I think those are the things. I think, we sometimes see these intensely syndromic sorts of things and can be confused, but I think the biology here is pretty consistent. Um, Treatment is hard, and a lot of support and networking, that's always very important. I mean, we think about future treatments. I mean, the problem is development. So, it's very hard we have people who say, well, can I do CRISPR or something? And it's not obvious to me how that fixes, a lot of the problems going forward.
Yeah, I think at least in this case, the syndromic feature of congenital heart disease is very distinct and easily defined, whereas in many of the other, like neonatal congenital causes of the rare syndromic forms, the other features are sometimes less difficult to tease out, or more difficult to tease out, the possible linkage and association that can be highly variable. So that's why I think that really, having that take-home message of congenital heart disease and diabetes deserves, testing of these genes, for sure. Um, Ava, could you just go back to the variant really quick? And I wanted to ask Bala, if if he recalls, so this is a missense variant. Uh, like how is there a reason why it was so easy to get to pathogenicity by this lab? Um,
Yeah,
in terms of, yeah,
based on the ACMG classification, they end up with pathogenic, but available information, I looked it now, it's likely pathogenic. But with the de novo condition and with the congenital heart disease phenotype,
yeah,
truly believe this is pathogenic and causal one because several other substitutions nearby this particular position 29496 previously reported with different amino acid changes, and also it is mentioned this position is very important for the data for function.
I
So
see.
yeah, exactly, this is positioned in the DNA binding domain also. So based on the rare allele frequency and the multiple lines of computational tool prediction with the reveal sky reveal score 0.924, this is true pathogenic.
I see. Yeah, I think that maybe alludes to why the GATA4 variants are a little less common than GATA6 in that all of the known GATA4 variants seem to be in this same specific location of the gene, whereas I think the GATA6 are a little more variable. But I completely agree with Paul that having the de novo variant in the baby affected with the congenital heart disease and now the diabetes, like just even taking that information alone, but along with this, the extreme rarity of the variant, totally makes sense. I would mention, though, by the way, that with GATA6, at times the parent, when tested, will also carry the variant, but will not necessarily have the congenital heart disease or the diabetes. And those are cases where we think possibly there's some mosaicism involved, which is something we see sometimes in some of the other genes. But in this case, having both parents tested and negative is definitely very helpful. So that's another reminder to anyone with genetic testing is very often testing the parents, testing other family members can be really helpful in clarifying pathogenicity, especially in these really rare types. But I think that may be all we got for this one.
I just and Kristen posted okay, she's gonna go, but she also posted the whole congenital heart disease, that the total thing is
Oh,
not
yeah.
that rare, but to get a syndrome like this, I'm sure is very rare. I don't
Yeah,
know.
no, actually, I'm glad Kristen mentioned that because, and we could probably go back and try to look at this, but as I recall, most of the congenital heart disease are, I think what are referred to as
Oh,
clonotruncal
yeah, yeah.
structural, like kind of more major structural
Mhm.
defects rather than just like VSD or ASD.
Yeah, but I think like still with ASDs and VSDs, like I think that's still one of the like the first line test is going to be a microarray. And I guess since in this case there's a delay between between the diabetes and the heart
Yeah.
disease, I'm not sure everyone's going to do
Yeah, I know.
single gene testing right away as instead of something. But now with that, like genomes are getting so much more, I don't know, feasible in the NICU setting, it might change. But I mean, I have a patient that was referred to me today who had she had a VSD and was diagnosed, I think she was diagnosed with diabetes in like her 20s, but like
Oh,
kids have it, like her. So I'm thinking, I'm like, oh, okay, like this is a very
well,
good thing. So just making sure that
yeah,
like I include
yeah.
that in my testing, but yeah.
Well, that might be a good place to start. Definitely let us know what happens there because that would be a really interesting case to present. But I agree with you that I feel like when I was in training as a resident, which, wasn't that long ago, but it was a little while ago, there was really no thought of genetic testing just for congenital heart disease, but I
Oh yeah,
would think
no, they do
as time
that.
goes on,
Yeah, yeah. I think it's, or at least like at our institution, they're doing like if there's a baby with a congenital heart defect, like they're going to order an array.
yeah,
And I think if there's something else, like if there's something else going on in the patient or family history, they might try to
yeah,
do an exome or a genome. But definitely, just thinking like, 22q or
yeah, exactly.
Turner or
DeGeorge and
something like that, depending on what the actual defect is.
yeah. But I would hope that those geneticists out there, they wouldn't necessarily just stop at the array, even though for
Mm-mm.
this one, it probably makes sense still to do that first
Mhm. Yeah, they
and
continue
then
to be followed.
I
Again,
see.
at least at our institution.
Yeah, I did have one case referred by an institution locally here who had congenital heart disease and had some high blood sugars
Hmm.
at birth, and I strongly encouraged them to do like comprehensive testing, and they were negative for any known causes, and then they went on to have complete resolution of the hyperglycemia, so it seemed to be probably just stress related. But I wonder though if there aren't other things out there, and these types of cases are certainly worth following long term and thinking in depth about these possibilities. And hopefully our not just our obviously our genetics colleagues are familiar, but our like cardiology folks and everything starting to understand more of the potential genetic underpinnings might know about these kind of things too. Cool. Well, thanks a lot, everyone, for joining, and those are some really great input from Kristen and Tony, um, and I guess we'll see everyone next
Yeah,
time.
and we don't know everyone, so but if you,
Yeah.
I don't recognize all the names, but if you do want to write in and have observations or cases to contribute, please totally do that. We are available, and we're going to continue. Ava, when's the next one going to be?
It's scheduled for Wednesday, May 20th at 2 o'clock. Mhm. You're muted, Lou.
Correct. So anyway, we'll see you then.
Take care,
Thanks,
everyone.
everybody.